Good morning, everyone. I like interactive talk, so I'm Monica Friedman. I'm pediatric rheumatologist at Arnold Palmer Children's Hospital here in Orlando. I'm really excited to talk to you all. I know it's super bright and early on Saturday, and maybe Disney's calling your name, so I am really honored to be here and happy to present this talk to you. How many of you know what AMPS is, just out of curiosity? A few of you? Awesome. Well, I am very happy to present this information to you for all your newbies and anybody who knows about this disorder. Hopefully, I'll enlighten you a little more about it, and we will take any questions at the end. So when I say AMPS, by the way, for those of you that don't know, let me start out there. Amplified Musculoskeletal Pain Syndrome, and we shorten it in rheumatology to AMPS because it's a very long name. So what we're going to talk about today is what the syndrome is and its symptoms, the underlying causes or presumed underlying causes, so we're still kind of trying to figure it out, and understanding key history and exam findings that we look for and things that you might look for in your children, and appropriate treatment recommendations. So I think first and foremost, we want to know what exactly is chronic pain, right? So it entails both recurrent and persistent pain symptoms. And typically for amplified musculoskeletal pain syndrome, which I'm just going to shorten to AMPS because it's a long name again, for AMPS, it's at least 6 months of symptoms. And it can affect any part of your body, bones, joints, muscles, soft tissue, and it really lasts more than the normal tissue healing time. So you injure your ankle, you sprain it, you might think, hey, this is probably going to be going on a couple weeks. But these pain syndromes last months and months and are really unexplained to the patient, to the parents, to the physicians a lot of times. So Dr. David Sherry is kind of the guru in AMPS. I went to visit his AMPS clinic up in Children's Hospital of Philadelphia. He did a lot of the research on AMPS from the beginning until where we are today. And his research really focuses on the different aspects of chronic pain and what we can do to fix it. So chronic pain is very common in pediatric patients. It affects about 40% of all children. And it really causes a lot of hospitalizations when patients come in with unknown pain, and a lot of hospital dollars go towards it because people get a lot of examinations and blood tests and imaging studies just to find out what's going on, because it really just baffles a lot of doctors. But there's certain components in rheumatology that we look for related to this syndrome, and a lot of it focuses on the psychosocial aspects that a lot of physicians may not think about. And there is a lot of economic cost to it because of the fact that we're doing a lot of unnecessary workup for it. The problem with this disease is that a lot of times it does evolve and progress into adulthood. So that's always a hard topic to discuss with the patient and their parents when they've already been dealing with it for so long. So what is AMPS exactly? So it's really an umbrella term for chronic non-inflammatory musculoskeletal pain. So that means in patients with JIA that you can also have a secondary AMPS situation. And I think that that is sometimes hard to differentiate for, number one, the patient, number two, the parent, and number three, the physician. So a lot of it is really based on history and exam findings for us and trying to really tease out, are we talking about a kid who's flaring, or is this related more to a secondary pain? And typically in a patient without JIA, there's going to be really no known cause for the pain. And we call it AMPS, or Amplified Musculoskeletal Pain Syndrome, because the body amplifies the pain. And we'll talk more about that, what that means as we go on. But a key feature of this disease, which is really hard for some physicians to grasp, is that they're not making it up. It's not that they're faking this pain. And we may not find anything fit on the clinical exam, but it's a real thing, and it's very gratifying a lot of times to patients when they've had pain for so long, and that a physician can acknowledge this syndrome, explain it to them, and then they really feel understood and feel heard. And I think that's something really important about this. So AMPS has many different names, and they all kind of blend into one diagnosis, but you may have heard of chronic widespread pain. You may have heard of juvenile fibromyalgia syndrome. You may have heard of something called reflex sympathetic dystrophy or complex regional pain syndrome. Those are kind of popular ones that you have been in the past. And I think a lot of you might have heard of the term fibromyalgia. How many of you have heard of fibromyalgia before? So fibromyalgia used to be what this was called for everyone. Juvenile fibromyalgia for pediatrics and fibromyalgia for adults. We tend to use AMPS now for pediatric patients because it gives off more of an understanding and acceptance of the diagnosis. So I think fibromyalgia back in the day had negative connotations. We understand a lot more about the disease, and we are able to explain it a little better to our patients. So I think that having a different name for it also helps to really recognize its importance. So usually we kind of will divide the diagnosis into two separate terminologies. So we have the complex regional pain syndrome, or CRPS, is usually one or two affected areas versus diffuse AMPS, which is really the entire body. We think of it from our diaphragm, so above and below the diaphragm. If you have pain above the diaphragm and below the diaphragm, more consistent with chronic diffuse AMPS versus maybe a single leg, that would be more under the CRPS realm. So a study done by Dr. David Cherry in 2020 looked at who is typically impacted by AMPS. So who do we worry about? And this was a patient registry. So we do a lot of patient registries. I'm sure a lot of you have heard of CARA, and maybe your kids are in CARA. And we thank you for your participation, because CARA is really important. Registries are super important to us because we're able to analyze data in patients and use it for years and years. So this data is around forever, and we're really grateful to you for that and allowing your children to be part of that. So this registry had 636 patients in it and found that the patients who are mostly impacted tend to be females in their teens. So median age around 14 years. It was in this particular group, non-Hispanic and Caucasian females were the majority of the patients, and the pain tended to last at least 18 months, which is really hard for a parent to see their kid in pain for so long without really understanding the diagnosis. And most of the time, it was diffuse and constant. So again, just thinking about your teenage daughter in constant pain is really a hard thing to grasp. So let's talk about what normal pain is versus what we're dealing with AMPS. So this is a nerve that we're looking at, and we have at the top the nociceptor, which really tells us about pain, and the mechanoceptor, which is really touch. So we're dealing with pain and touch. So you have a noxious stimuli, that's the little yellow triangles that cause pain signals, and that'll trigger that pain response. And then touch, we're talking like a feather tickling you, is going to cause a mechanoreceptor to trigger. Now that's our normal sensation. So everyone is going to feel pain with something, right? The example I give a lot in my clinic is a patient is hit with a hammer on their thumb, right? And you feel that throbbing sensation. So that's your nociceptive system causing pain. And then what happens with AMPS is that we get something called hyperalgesia and allodynia. So those are big words we use in medicine. We'll break them down. Hyperalgesia is heightened sensitivity to pain. So essentially, that throbbing sensation is 100 times worse for a patient with AMPS. And we have allodynia, which is heightened sensitivity to touch. So in those two mechanisms we were talking about before, you're going to get heightened pain with that the nociception, and you're going to get heightened sense of touch. So essentially, that throbbing thumb never goes away. Even when the hammer is no longer in existence, you're still going to feel that throb, and it's going to amplify all the time. And a lot of kids who get amps have what we discussed just now, allodynia, skin pain, and they really don't like to be touched. So patients will claim that a hug really hurts them. And that like breaks my heart because, you know, everyone needs a really good hug from time to time. So to know that this causes pain and discomfort, patients tend to shy away from being close to anybody because it's so painful. So this is the picture that is famous around the world for amps, how we describe it in our patients. So essentially, you get hit with that hammer on your thumb, your pain trickles up your thumb, up your arm, up to your spine, to your brain, and you're like, ouch, right? So for most of us, you take the hammer off the thumb, the throbbing continues for a little bit and then kind of fades. But with amps, that pain cycle continues. So your brain still triggers that's a signal that the pain source never went away. So you still have that hammer banging on your thumb constantly. And it can cause certain different changes to our body. It's very interesting with CRPS, if you're talking about just in a lower extremity. I'll show you some pictures later on, but patients can actually get discoloration of their leg. They can get swelling of that leg. So it can mimic arthritis and really can be difficult for some clinicians to differentiate. So how do we as rheumatologists diagnose this? So there's usually a certain way that a history is presented to us that we can really understand what's going on with the patient. And it also stems around the exam findings. For a patient without JIA, it's a little more concrete. With patients with JIA, it gets a little more tricky because, for instance, if you have a kid with CRPS with a swollen joint, you might wonder, is there arthritis flaring or is this something else? So it's pain for an extended period of time without joint swelling or morning stiffness when it comes to diffuse amps. And arthritis will be under control at the rheumatology visit. So patients will tend to complain about only pain in this setting when we're talking about diffuse amps. And it won't be related to their morning stiffness. You know, morning stiffness is such an important feature of arthritis. Patients will wake up in the morning, feel stiff for about 30 minutes, sometimes limp around the house for a while. You know those, right? How many of you have had kids who do that? Yeah, so kids with amps will talk about being stiff in the mornings, but not to the extent of an arthritis patient. And I have patients who will blatantly tell me, this is a different pain than my arthritis pain. And that's really helpful if they're able to distinguish, but sometimes it's really just not something that they can really understand. So the other key feature is that they're not going to improve with their arthritis medicine, except when we're talking about Tylenol or Motrin, because sometimes that does help with amps. So when they take their methotrexate, a lot of times they'll feel my arthritis is getting better. Or I know people swear to me that when they get their Remicade infusions, maybe a few days before, they start to feel the pain come back, and as soon as they get the infusion, they're feeling better. So that would be more, hey, that's probably my arthritis that's acting up a little bit versus amps. And again, pain with hugging and light touch, like we discussed before. So the other feature when we're examining a patient is the pain will be out of proportion to what we find on the exam. And kids really tend to hide the emotions well with amps. So you have to really understand a true amps patient and see how they are and understand what they're going through to know that they're in a lot of pain, because they'll sit around smiling at the visit and then just tell you they have pain in every single joint. And they'll be calm, and when you examine them, they might wince a little in pain, or some of them are just, you know, in severe pain, you touch every part of their body and it hurts. But they're able to sometimes mask that from physicians and parents and to how much pain they're in. So we have to kind of, you know, tease that out of them. And again, skin pain for us, we can actually, when we're examining their joints, they will be wincing just because of light touch on exam. So that's a little more of a feature for amps. So what is a main trigger for amps is stress. I know we're all dealing with a lot of stress in our lives, and stress can trigger a lot of things for a lot of people. this is one of those diagnoses where you wear your emotions on your sleeve in the literal sense. Patients will tell me that when they are stressed out, that their pain is worse. And that's one of the key features that helps me to differentiate a lot of times between JIA and AMPS. And a lot of times it stems around a major life event, like a death in the family or school stressors. And another feature that I notice a lot is summertime, kids are doing great. They're out of school, they're not stressed out about exams, they're not dealing with bullying. And the second that school starts back up again, their pain symptoms come back. And a lot of times this is in the families. We'll hear a lot of patients who have a mother or grandmother with fibromyalgia or an aunt, and they are looking into the genetics behind fibromyalgia and AMPS. We don't have a whole lot of information, but I do know that there are finding some genetic components to this diagnosis. And you can tell they actually have kind of a specific personality type too, tend to be more mature, more people pleasers, high achieving perfectionists. So I will be able to kind of talk to the patient directly and be like, hey, are you one of those kids that has to have your homework perfect? And if you have one line you have to scratch out, you crumple it up and throw away and start over, and you're in all the extracurriculars and you're a straight A student. They're like, whoa, how did you know all that about me? But that's really just a key feature of this. And they tend to start withdrawing from school or activities because it does get really tough. Pain is really depressing. So that it's a cycle. It's a vicious cycle of pain that leads to poor sleep, leads to depression, anxiety, and then it just continues on. So this might be a little hard. Oh, no, it's good for you guys. Okay. So it's multifactorial in what's involved, the psychosocial element, the environmental element, biological history, and psychological history in the family we look into. So these are all the features that we focus on when we're trying to diagnose this in a patient. The other key component of this, it's not just pain in the joints, we also notice pain in other areas. So frequently we'll have patients with chronic migraines or chronic abdominal pain. Have any of your children been diagnosed with hypermobility syndrome? A good handful of you. So JIA a lot of times can coexist with a diagnosis called benign hypermobility syndrome. I happen to have it, so I can kind of give you a little feature of it. So you're very bendy and you're hyperextensible. Sometimes I gross people out with that, sorry. But it is also a feature that helps us to differentiate if you're hypermobile between a JIA flare and not, because a lot of times that joint that's flaring will not be as mobile as another joint. And patients with benign hypermobility syndrome actually tend to have a lot more associated AMPS as well. So when you have the combination of JIA with the hypermobility syndrome, AMPS is kind of potentially a risk factor. POTS. Anyone have a patient with POTS? A couple of you. POTS goes along a lot with benign hypermobility syndrome, and AMPS, it's a postural orthostatic tachycardia syndrome. That's when you get dizzy when you stand up too quickly. There's a lot more to it. Tachycardia is when your heart is beating really fast in your chest. Anxiety and depression are a key features of this, and suicidal ideations, unfortunately, that's when you have suicidal thoughts. 18% of the patients. So that's really scary. So we really need to be able to tease out what's going on with our kids, with the patients, so that we can make sure they're safe. And then you can get functional neurologic symptom disorder. That's conversion disorder. That one is tricky. It can cause loss of function in some of your joints. I had a patient who developed AMPS in conjunction with conversion disorder, and she was not able to walk. Just one day woke up in the morning and lost feeling from her waist down. She was in a wheelchair for a while, eventually to a walker. And then I went to her high school musical right before she graduated high school, and she was running around dancing in heels at the show. It was fantastic. It was amazing. So there is hope. for this diagnosis. You just have to put a lot of effort into treating it. And that's a little bit of a passion of mine because it is a really tough disease to treat. So that kind of other umbrella term we talked about, complex regional pain syndrome. So this is a really interesting disease in the sense that your body makes physical changes in conjunction with the pain. So patients will get skin discoloration, swelling, and sometimes even contractures. And there's really no definable nerve injury. You go to neurology and they will do their nerve exams, they'll do MRIs, they'll do nerve conduction studies, muscle biopsies sometimes, and nothing will be abnormal. And this is typically seen in the legs, the lower extremities, but it really does look a lot like JIA, right? Your patient or your children who have ankle arthritis might be hard to differentiate between this and arthritis. Some of the features that kind of differentiate it for us as physicians is you'll put your hand on that foot and it'll be ice cold. And that purple discoloration really doesn't go away. And the contracture kind of comes on suddenly. We know patients with JIA, their contractures take time to come on. I had a patient the other day with this, her foot was completely turned in, purple and just stuck, and it's stiff. You couldn't move it at all. She went to physical therapy for a couple weeks and it just kind of opened right back up. So again, like I said, there's hope for these patients. We just have to take that a multidisciplinary approach. So talking about treatment, here we go. So what do we do when we suspect our patient might have AMPS? Well, I say talk to your rheumatologist, right? Most rheumatologists are equipped to diagnose it, but some may not really be interested in treating it. There's a certain few of us that take a passion in this diagnosis, and we really want to help these kids get better. So a lot of rheumatologists who don't feel comfortable so much treating it will send to other rheumatologists who kind of focus more on this. They did a study in 2018 about medication use in patients with AMPS. They identified 120 adolescents, so a pretty large study in pediatrics. And 70% of them used at least one pain-specific medication, whether it be opioids, which we know about the opioid epidemic is terrible right now, non-opioids being like Tylenol, Motrin, psychiatric or neuropathic drugs, that includes like your antidepressants, anti-anxiety medications, or other classes of drugs like gabapentin and Lyrica, if any of you have heard of that. And it really showed a lack of proven efficacy for widespread medication use. And there were patients seeing doctors multiple times over for pain, 15 doctor's visits a year, and they missed at least 2.6 days of school per month. So that's another thing that's very difficult with AMPS patients. They're missing a lot of school. So it's really essential to diagnose it as soon as possible so that we can take measures to get them better so that they can live normal lives and reintegrate into school. Because a lot of patients end up in hospital homebound or homeschooling because it's just too much for them to be in school. And there's also strong correlations between disability reports and medication use. So a lot of patients end up on disability with this, which is really terrible. So Dr. Sherry's team is less into medications for this. I find that offering a multidisciplinary approach for patients is really important so that families feel like there's a lot of different options we can do. So best treatment approach, according to Dr. Sherry, who's the main guru who really focuses on this solely, is non-medicinal, so no medication. But I do feel like sometimes there's a role for medication in the more outside world of research, right? You know, as pediatric rheumatologists in the community, it's hard to tell a parent there's no medicine we can help you with. We're just going to do what they do in the research setting. So I think having different options in the community is really important too. So our main goal is restoring function. So a big question that patients ask me is, my pain ever going to go away 100%? And I am a rheumatologist, for better or for worse, that's honest and upfront with my parents and patients. I don't like to sugarcoat things, and AMPS is tough. If I get my patients back to 80% function and 80% decrease in pain, I think that's a real success. And that's a hard pill to swallow. I mean, you're telling me, if I'm a parent, that you're not going to get my kid's pain to go away, that's like really disheartening. But I think over time, we all learn to deal with pain. I mean, how many of you wake up in the morning with just a little backache and a little bit of knee pain, and we just kind of get through the day? So I think that we want our kids to be 100%, but I think we also have to think of the reality of the world is that everyone has a little bit of pain, that we just kind of walk it off every day. So as much as it's not perfect, we can get them back to functioning, and I think that's the most important. And the way that they approach treatment of this is a little bit counterintuitive. You want to push through the pain, which is a really hard thing to tell a parent when their kid is crying, when you're pushed, when they're in physical therapy, and that movement of that arm is just really hurting them. And it really does get worse before it gets better. And again, we're talking about kids here. Who wants their kid to be getting worse before better? It's really difficult, but it's really not a damaging diagnosis. There's no chronic deteriorative changes that happen. So pushing through the pain, as hard as it is something that we have to do to get better. And we see amazing results when we do. So there's always mnemonics. I've never been a fan of mnemonics, but this one is ABCs, so pretty easy to remember. So A, aerobic exercise, including physical and occupational therapy. So that's our #1 best treatment for this, which is a little different than arthritis, right? Arthritis, we are really more pushing the medications because we know about the inflammation going on. There is physical therapy definitely involved in a lot of arthritis patients, but AMPS is very much physical therapy heavy. And behavioral health referrals and psychological counseling is so important. I actually have a mental health counselor in my office. I hired her specifically for my AMPS patients. She works with a lot of my other patients as well, my arthritis patients, my lupus patients who are struggling with chronic disease. But because AMPS is such a psychological issue in terms of it really just exacerbates with the anxiety and depression, I find that it's so important to have both mental health and physical improvement. And that will kind of key into my keynote later. Dr. Barreto and I will be doing a discussion on emotional health and JIA, so we hope you can join us for that. The C component of this is curbing over-medicalization and discontinuing medications. This is more just trying to get rid of the opiates. I think as a physician who really focuses on AMPS, I do not prescribe narcotics to any of my patients, and that is sometimes hard for parents to watch their kids in such severe pain, but there is no documented improvement with narcotics in these patients, so I really focus on the other aspects. Desensitization techniques is a really important feature of this, and education. Education is huge. So what is desensitization? So we talked about how this is hypersensitivity, overstimulation of our nerves. So desensitization activities actually work to take that hypersensitivity and decrease it to a normal level where we can tolerate it. So let's go back to that thumb example, that throbbing sensation. What do we do when our thumb is throbbing? We rub it, right? I mean, I do. I don't know what you guys do. Maybe you hit a wall or just cry. But for me, when I feel that throbbing, I have this instinct to like twist my finger and try to like get that throbbing to stop. That's inevitably actually a desensitization exercise that we do without even thinking about it. So desensitization exercises, especially in patients who have a lot of skin pain, is really the patient working on their own to take that nerve hypersensitivity and decrease it with techniques that are not, for us, would be normal: a rubbing of the arm, a towel massage, lotion massage that we would just do on an everyday morning routine. But this is tough for them. So learning how to cope with those nerves and decreasing that sensitivity is really helpful to improve this diagnosis. So a key feature of behavioral health is something called cognitive behavioral therapy. How many of you heard of cognitive behavioral therapy? Oh, good, a handful of you, I like that. So this is a triangle of thoughts, behavior, and feelings. So you identify the stressors, you learn the coping techniques, and then you assess and treat the comorbid conditions. So essentially, what we do with cognitive behavioral therapy is we take an uncomfortable situation and we talk it out with the patients and say, how can we make this less uncomfortable for you? So that's how we do it with pain. We say, what thing do you do that you used to love to do? So patients used to be athletes. Most of them have, were dancers or were gymnasts, competitive tennis players, and now they can't do that. So you try to take an activity that used to be fun for them and figure out a way for them to cope with the pain and continue to do it and do it more and more so that it gets easier each time. These are the desensitization techniques I was talking about. Sensory disorder patients, it's the same concept. You're taking brushes sometimes, or the vibration or head massagers, and you just work on just simple brushing or simple scratching or simple massaging to help. And CHOP has a really great video for any of you who have patients who have AMPS about how to do these desensitization exercises and doing them 4 to 5 times a day for a few minutes a day. I usually tell my patients, hey, go watch a TikTok video or a YouTube video and do these exercises while you're watching that. And by the time you're done with the video, you'll be done with your exercises for that particular time frame. I actually got to experience an inpatient rehab facility at CHOP, Children's Hospital Philadelphia, with David Cherry. He started this many years ago, and I was just absolutely fascinated with how it went. And in fact, we're starting a similar program here in Orlando, which I'm very excited and passionate about, for patients with AMPS. And patients travel all across the country to go to this rehab in Philadelphia. And essentially, it teaches patients how to function on their own. It's very hands-off, which is very different for anyone who's taken their kid to physical therapy. The physical therapists are very hands-on, range of motion exercises, trying to work on the contractures for the arthritis patients. This is, hey, what can you do on your own, and how can we get you functioning better? And the concepts are very simple, right? This is a picture of a kid with a pencil and a paper. I mean, we could do this at home. I joked that I could do this clinic in my basement with the equipment that they were using in their hospital facility, because and that was what I was willing to do, to be perfectly honest, because I wanted something that I could provide to this community here to help these patients, because they really do suffer. But this is working on occupational therapy and physical therapy at the same time. This kid has to lift her leg up and stand on one leg and use a pencil on her toes. I mean, so all of these are fine motor skills, they're gross motor skills, and these all help to reduce pain. This was another activity I found very fascinating. This kid was standing on a textured disc. So she had CRPS. She had to deal with that sensation of those textures on her foot. She had to use her toes to do occupational therapy exercises. And she also had to stand on one leg, so it was balance issues. So, I mean, again, you see how simple these things are, but they're so effective. It's pretty mind-blowing to see the improvements. And I got to meet a few of the patients at the clinic and see their progression in just a short period of time. So a lot of times outpatient physical therapy is months and months and months. This inpatient rehab is 2 to 3 weeks, and it's really intensive, and they end up being able to function so much better from it. This was another picture. This girl had actually been there the longest they had ever seen. She was there for 9 weeks. She had a CRPS in her right foot. It was contracted, and now this girl was actually a tennis player. So they try to get them functioning with activities that they like to do. So she has a tennis racket there. So she had to go through this obstacle course like 10 times. And she would bounce her tennis ball so she'd get back to her regular activities. And just watching the process was just really, it was really special. So what's on the horizon for Arnold Palmer? I just figured I'd plug in. If any of you are looking for an outpatient program, we tried to do an inpatient. It was a little difficult with insurance companies. So we're doing like a half-day intensive outpatient rehab program focused on all the things we discussed in this talk with exercise, physical therapy, occupational therapy. We're going to have music therapy and art therapy and mental health counseling and all of that. Those are all key features for AMPS, and patients from around the country are going to be able to come to our outpatient intensive program, and you know, we're super excited to be able to offer this to anyone who needs it. So you can talk to your rheumatologist about it. It's going to be 8 a.m. to 12 p.m. with an average stay of about 2 to 3 weeks, and it's usually Monday through Friday, and you do all the things I just spoke about. So maybe this sounds a little hokey to you, but I have data here to show the response to these programs. So this was the outcomes from previous AMPS programs in the country. After 1 month, roughly 80% of the children had no pain and full functionality, which is pretty phenomenal. We're talking about physical therapy, occupational therapy, mental health counseling with an 80% improvement. And then another 15% fully functional with just mild pain, and only about 5% that weren't better. I think those are better odds than our arthritis medications, to be honest. And then significant relapses, unfortunately, or fortunately, sorry, in this situation were infrequent, but 15% did require some sort of medication at some point. And then 5 to 10% do develop a different symptom of psychological distress over time. But the real key feature I want you to focus on is that at 5 years, 90% were still doing well. So it does work. It's a long process, and it's sometimes a hard pill to swallow, as I've said before, but it can get better. So in conclusion, I know I had a lot more time to talk, but hopefully we'll have some good question and answer session. AMPS is a multidisciplinary, non-pharmacological in research settings, and in community settings there is some pharmacological success, but it's long-term success if you do it right. You want to focus on restoring function, and that in turn will reduce your pain. And you want to empower patients and their families to take ownership of their own treatment, which is really important here, is that you take the time and energy to learn what works best and to help your kids out to get better from this. Thank you. So it looks like we have 36 minutes, so we've got a lot of time to answer questions. So if anyone has them, I guess come to the microphone. And I know on virtual world, if anyone has questions, I'm happy to take them.
First, I just wanted to say that my daughter did an AMPS inpatient program in New Jersey at Children's Specialized when she was a senior in high school, I believe. And the first half of, no, maybe it was a junior, don't remember. But the first half of the year, she missed more than half of the days of school and needed a lot of homeschooling. And after the AMPS program, she did not miss a single day of school. Now, I'll tell you that I cried every day like she did. It was very difficult. She'll tell you it was torture, but she'll say it was the best thing she ever did. It's intense.
Yeah, thank you for that story. I love that. Yeah.
The second thing is, what age are you taking in your program? That's the outpatient program.
I don't think we've had an age cutoff yet, but typically the youngest age that I've ever seen diagnosed is around 8. So, I mean, I think we'll take any. You're talking about up to?
Right.
I think
Philly only takes up to age, I think, 16.
Yeah, I think we were talking between 18 and 21. We're still trying to work out the details, but yeah, you know, each case I think will be individual, and then eventually we'll have a set age range. I know we talked anywhere from 18 to 21. We're still kind of working out those details, yeah.
Yeah, New Jersey's inpatient program takes, we did that over Philly because they take up to 18.
Yes. Yeah, we're still, we haven't launched yet. Our launch date is planned for August 15th. So we still have a few kinks to work out, and, you know, we'll know, I'll know a little more later on about the cutoff that we decide at the
Do you
end.
know any adult programs?
There is one at Mayo, but it's more for POTS and dysautonomia. I don't know specifically fibromyalgia ones. I can definitely look into it. There's a lot of pain programs around the country. There's about 83 pain programs around the country, and about, I think 50 of them are pediatric, have pediatric programs too, but will be the 9th AMPS program in the country. So this focuses solely on AMPS. So I don't know if there's necessarily AMPS or fibromyalgia programs in adults, but they do have a lot of pain programs around the country that are similar to this.
Do you know why Lyrica and gabapentin do not work for this in children when it works for fibromyalgia in adults?
So from my personal experience, I wouldn't say gabapentin and Lyrica don't work in pediatric patients. The studies that they did found, they looked at all the different types of medications pain medications that patients were on, and I think the majority of them were on opioids. So opioids are narcotics, or your Percocet, your, Dilaudid, all the terrible narcotic pain medicines that don't really help. Those they looked at and didn't really see a difference. I don't think they isolated necessarily. I think there are, obviously, anecdotally, from my perspective, patients that do respond to gabapentin and Lyrica, and I do put a lot of my patients on them if that's a choice the patient wants to make. So I don't think I have the study numbers because that's not what they were looking at. They weren't specifically looking at those two drugs in pediatrics, but they just found that there was such a significant response to physical therapy that was their main focus for all this time. So,
what are your thoughts about medical marijuana?
So interesting question. My hospital is not like totally. I'm a DO. I'm a doctor of osteopathic medicine. So I've done a couple talks at the Arthritis Foundation on complementary therapies. So I am a little more east meets west in terms of my treatment. So I do acupuncture as well, which I'll tell you, I started acupuncture because of my AMPS patients and having very little to offer them in terms of like immediate success. And I love that aspect of it. And I think that there is a role for some patients. I am totally not against medical marijuana. I was asked by a physician to become a medical marijuana physician at our hospital. It's a little tricky. It hasn't come to fruition yet. It may in the next couple of years when people are a little more open-minded to it. But I do think that there's a role for whatever works for your child. I have several patients who are using medical marijuana and have seen some great success in AMPS. This was even before it was really approved or accepted in the pediatric community. Scary enough, I had a mom tell me she was making a tincture in her kitchen, which really was a little hard for me to grasp, but was just very happy with how they responded to it. So I am open-minded to whatever helps your child. I just am very against opiates because I don't see the benefit and I see the damage it causes. So, anyone else?
Hello,
Hi.
I'm Heather. I'm from Georgia. I have a 19-year-old who was diagnosed with AMPS when he was 11. We did do the program at Boston Children's Hospital. It is very intense, like you've heard. It did him good, though. We did it in 2019. At what point are you seeing the relapses of kids that need more intense therapy after they finish the program?
So I don't have exact numbers because I haven't been doing research yet. I will be starting into that network of research. I do know just in general that any trigger, like stress trigger, can cause a flare, right? So in these patients, I think they could have triggered anywhere from, some of them didn't completely recover all the way. So then within a few months, they triggered and flared again. But the majority of times you can have flares that are much less severe because you start back in your physically intensive activities and you know what works for your child, and then they can be a lot less. So it could be anywhere from months to years, but I would say in general, patients who might not necessarily have done the intensive program, but who are in my clinic every day, who are doing outpatient physical therapy, tend to do, like I said, it's waves, right? So they'll be perfect during the summertime, and then the second school starts, they flare. So I think just knowing triggers and knowing how to get to a better place right away and starting those. So I start my patients right back in physical therapy the second they feel like they're flaring, and that really reduces the dramatic long-term effects.
Thank you.
We do have a question online.
Excellent.
Amy writes, can you offer any advice how to explain AMPS effectively in order to gain the trust of disbelievers? We have family and friends who feel that AMPS is not an actual diagnosis. My daughter's pain is real, but because she looks fine, it's not fully understood.
Sure, I mean, I have to make parents believers too, like of their children. So I think that's a struggle that we face every single day with this diagnosis, because the patient, like I said, will be sitting on the exam table smiling. So I think that all you can do to people who don't understand this is educate. So education. So resources, you can go to the Arthritis Foundation. I know they are going to have some resources for AMPS. The different AMPS programs around the country will have definite resources online. CHOP has a lot of resources for it. But I usually go back to that picture I showed with the brain. I think that really helps to solidify the diagnosis for the patient and parent, because it really helps them understand what's going on in their body. Because again, there's not a lot of physical findings for the diffuse AMPS, so it's really hard for a parent to understand what a kid's going through. And then you just kind of show this brain and explain this hypersensitivity of the nerves, and all of a sudden it just clicks. And you see this almost like sigh of relief come over the patient when you're able to explain it to their parent the way that they've never been able to explain it. So I just think really getting good resources and educating family and friends is really all you can do. I mean, there's non-believers in everything, right? So we just have to be able to provide the information to them appropriately, and hopefully they can eventually learn to understand it. But AMPS is one of those diagnoses that a lot of people may never understand until they've experienced it, whether it be themselves or a family member. So, or a physician like me who sees it every day. So I understand your struggle, Amy, and hopefully with some good resources and good education that your family and friends can be a little more understanding. So, anyone else?
The same writer asks, can we contact you via email if we have any further questions?
Absolutely. Yes, I will. I don't know if you provide my email on the website or what is easiest. Sorry, Heidi, I can't hear you. They can get it onto the website? Okay, yes, my email will be available on the website if anybody would like to send me questions, for sure. Does anyone else have a question or a story they'd like to share? I love these stories. It's really helpful for other parents to hear.
Sorry.
No, I saw you in the back. I thank you for coming up and sharing whatever you have to share.
First of all, is this session being recorded?
It is, yeah. It's a hybrid session.
So, is phantom pain the same thing as what you're talking about?
Is phantom pain what I'm talking about? Yeah, so there's something called causalgia, which was one of the terms I didn't talk about, but that was where this actual diagnosis first came about in World War I, when soldiers would lose their leg and get phantom pain. That's how this kind of first came about. So for patients who may be missing a leg or an arm, developing phantom pain, yes, definitely under that umbrella term for sure.
Okay, 'cause today's the first day that I've heard of AMPS,
Yeah.
but my son is 9, and we're little less than a year. And our doctor recently said that she thought he was experiencing phantom pain.
Mhm.
So we actually, we live in Texas, and we have an appointment next week at Texas Children's, the pain clinic.
Yeah, I used to work at Texas Children's Hospital.
Okay,
Yeah.
and she said there's gonna be a team of doctors.
Yeah, I know that program very well.
Okay, so a pain management doctor and physical therapist
Yep.
and a children's psychologist.
Yep. There's also an integrative medicine program over there that I was a part of the pilot for. There's some yoga and massage therapy and acupuncture. There's a whole lot of resources at Texas Children's Hospital that's going to be great for your son, yeah.
Okay, so we're going next week.
Do you have a rheumatologist there?
Yes, ma'am.
Who's your rheumatologist?
Dr. Lay.
Dr. Lay. Dr. Andrea Ramirez was a partner over there who's amazing. She and I actually were hoping to start an AMPS clinic over at Texas Children's, but she might be a good resource for you as well for AMPS over there.
Okay, and I just also wanted to ask how you felt about what you thought about the, I don't know if I'm saying this right, CBD oils and lotion.
CBD oils? Yeah, so hard to say about those if you're not getting them from a real dispensary. I did watch a lecture from the Florida chapter of osteopathic medicine. The physician president over there was talking about those different CBD concoctions, because I'm not as familiar with them. A lot of people buy them at the mall, right? Spend like $120 on a jar. Those are not FDA regulated, so you might be getting not as much as you think of the actual CBD or hemp. Some of my patients swear by them. They say they rub it, decreases their anxiety, decreases their pain, and if it's over the counter or at the mall, then easy to access. So I think it's worth a shot if you can afford it, because it is expensive. But in terms of getting the real CBD creams, the real CBD oils at the dispensaries, yeah, I think those can be very helpful too.
Now, the term AMPS, is that a new term?
Sort of. Over the last, I think 10 years or so, that's kind of what, it used to be juvenile fibromyalgia, and now we've moved towards AMPS. Yeah.
And
so,
what are your, so on the, you're talking about the program for treatment, and you talked about physical therapy, or what about the aqua therapy?
I love aquatherapy. Anyone who has JIA or are AMPS in my clinic, I always offer aquatic therapy first, because there's no gravity, right? We're floating, and it's much easier when you're having a lot of pain, or you're limping, or you have, arthritis in your toes, or you can't walk on your feet because your pain is so bad, that those exercises are a lot more tolerable in the water, because you're not having to put pressure. For me, standing up here, I have flat feet. I'm hypermobile. I get a lot of pain in my feet. So I don't know if you see me shifty. I'm a little shifty up here. So when I'm in the water, I don't feel that, right? So I think aquatic therapy is amazing.
The aqua therapy, so that's good treatment, not just for arthritis, but also for the AMPS.
It's a wonderful treatment for AMPS. If a patient really can't move with AMPS, they're just really struggling, I'll get them in the water first, because it's a little bit lighter therapy than, the exercise machines. And they'll be able to start with aquatic therapy, and they eventually end up in land therapy, is what we call it.
And do you know if that's offered at the Texas Children's, if the aqua therapy is?
Oh, goodness. What did I do for aquatic therapy? I feel like there used to be a pool there. I honestly don't know what's going on now since COVID. I think a lot of pool therapy has been a little bit difficult all around the country because of COVID. A lot of people closed down their pool therapy, but I would definitely talk with the docs over there. They should have an idea for sure.
We have an appointment next week. So.
Fantastic, good.
Anyway, thank you.
Oh, my pleasure. Anyone else? Did you have a question?
I didn't so much have a question. I've got my favorite oldest daughter who is
Is that your only daughter?
17. No, I obviously have a favorite youngest daughter also.
Fair. My dad used to tell me that I was his favorite child for 10 minutes. I was one of 4. So every 10 minutes he'd have a new favorite. So I appreciate that, yeah.
There you go. Yeah, if I also have a favorite blue-eyed daughter and a favorite brown-eyed daughter.
Oh.
Had we had a third, her eyes were going to be hazel no matter what shade they were, because I had backed myself into a corner. My favorite oldest daughter was in elementary school when the amplified pain became overwhelming, and we spent her 4th grade basically running her in a Bob's stroller every day and having her on a beanbag chair, and she was napping, and the accommodations in the school were very helpful.
Yes.
They were very unhelpful in terms of the 504 IEP process, but the teachers were great. And one of the things I was going to point out was someone earlier asked the question about how do you tell like friends, family who don't believe. Go online and do some YouTube Googling. What we ended up doing, Marilee looked perfectly fine. And what we ended up doing was putting together a little short video to explain how the nerve cycles amplify, and all of the kids kind of got it after that.
Yeah.
And we have a bunch of small elementary schools, so all the schools that didn't get that, you could tell the difference between who had been educated. So I think that was a really good recommendation, and you really should follow up on figuring out the short elevator speech, if you will, about how it works. Both daughters went through the PPRC, which is like CHOPS. They're all the programs are slightly different,
Yes.
but similar. So to the question about the aquatic piece, I think for my older daughter, it was very helpful. In terms of relapsing, one of the challenges that you have with amplified pain is that you don't always know if it's amplified pain or if there's an actual injury. So you can talk about a trigger like a stress trigger going back to school. Another trigger can be an injury.
Yes, that's very true. A lot of CRPS, for instance, will be triggered by a minor injury like stepping off the sidewalk the wrong way, something very simple. So yeah, I had patients one of my patients was singing in her closet for some reason and smacked her wrist against the wall and developed CRPS just from something simple like that. So yeah, it's a very good point. I appreciate you bringing that up.
So in our case, Marilee went through the program and came out stronger than she'd ever been, which was phenomenal to see. And about 7 weeks later, so she went from being completely not mobile to playing soccer, and about 7 weeks in, she got kicked in the shin, and
Yeah.
everyone said the medical system, and I want to emphasize that I thought we had really good doctors who cared and were well informed. But she got diagnosed that, well, you got kicked, it triggered a pain syndrome. And one of the approaches with the pain is that you move the joint.
Correct.
You continue to try to reset the nerve cycle. And if it's getting worse, that usually means it's non-amplified pain. If
Sure,
it's getting
yeah.
better, that usually means it is. And in her case, it didn't get better. And we went 3 times to the pediatrician, and we had the x-rays and yada, yada, yada. And finally, I just said, we need to go to an orthopedist because, you know, this is not working. And it turned out she had a stress fracture. And that set of misdiagnoses is a huge trigger for her. And to this day, and she's a senior in high school, there's a trust of the system
Sure.
question. And if she doesn't like the answer, she, you know, will revert to that
Yeah.
scenario. But in terms of triggers, that's one for her that, you know, having had all the misdiagnoses along the way or before it was identified, they're pretty sensitive to that. And some of the emotional and mental health issues that came out of that were significant. So I don't
Yeah.
have anything question-wise to ask, but I would say that the program, the intensive programs are really amazing. Do your research between the different ones about what seems to be a fit. Obviously, we were lucky. We were close. We had one. We were in Boston, in Waltham, Massachusetts, for the program. But we had one from Arizona. We had one from Florida. We had one from Ontario. You know, and so I'm not sure which was. In our case, it was better. We had the second daughter, they're 15 months apart. It was good that we didn't have to split up. But
Yeah, that is a problem with
programs
the
are great.
program, is that sometimes you have to pick up and move to where, not sometimes, you do have to, if you don't live in the area, you'll have to pick up and move for a couple weeks to the program, so.
Yeah, and the length of time for them was typically 3 to 4 weeks. So
Correct, yeah. We're still figuring ours out. We'll let you know the data soon.
I was going to say they've got their billing figured out, because
Yeah,
that would be a good resource in terms of how to approach some of those questions.
thank you. Yes, we've worked on those details. We're gonna evolve over time, we'll see. But I thank you. I'd love to see your video, if you can email it to me, the YouTube video. Also, he brought up a point about the 504 and the IEP. I think there's a talk on that this morning for how to get your kids involved with the, because I was gonna discuss that too, but I think that it's a really important thing for school that you look into that with your guidance counselors, and it's happening right now. So will they be able to watch it later? No, they won't be able to watch it later. Okay. So 504 plans are, do you guys all have 504 to IEP set up for your patient or your children? Maybe half of you? Does anyone not know what that is? Okay, you all know what it is. Great. So AMPS, we have like kind of a certain way that we manage IEPs, in the sense that a lot of times the patients do better later in the day, or they do better they struggle with certain classes at certain times of the day. So a lot of times I will have them be able to go to school a little later, or move their harder classes to the time where they're more receptive to the information, so they can do better in school. I used to be a firm believer in everyone being in school, and I still feel that's the most important, is to be interactive with your friends and not be home and homeschooling. But I do see sometimes the benefit to it now. Being in this pandemic, it's opened my eyes to homeschooling and Florida virtual school that we have here. But I think really trying to integrate your child back into the school system is really important. So. Anyone else have any other questions? Anyone online? Mom, do you have a question for me?
Nothing further online.
Perfect. Well, I thank you all so very much for sharing your early morning with me, and I'll be up here if anyone has questions for me later. Thank you.